Picture this. A patient bursts through the emergency department doors, completely pale, sweating, and clutching their chest. It's literally one of the most terrifying, high-stakes scenarios you can encounter in medicine, and the second it happens, the clock starts ticking. But solving this medical mystery, it isn't just about panicking and jumping to a single conclusion. It's actually this incredibly structured, fascinating process of elimination. So in this explainer, we're going to walk through the chest pain puzzle and uncover exactly how doctors crack the case. To really wrap our heads around the sheer scale of this challenge, take a look at this number: 6 to 7 million. That is the staggering number of emergency department visits for non-traumatic chest discomfort in the US every single year. I mean, it's consistently one of the top 3 reasons people seek emergency care. The resources it takes to evaluate millions of these cases are just monumental, which makes it absolutely crucial for medical professionals to have a flawless, streamlined system to separate the harmless issues from the deadly ones. Now, right off the bat, there's a massive plot twist in the data. If you ask the average person on the street what causes chest pain, they'd immediately say a heart attack, right? But when we look at the final discharge diagnoses, the leading culprit isn't the heart at all. Gastrointestinal issues, things like acid reflux or esophageal spasms, account for a massive 42% of cases. That significantly outranks ischemic heart disease at 31%. Chest wall syndromes come in right behind at 28%. But because the heart issues are the ones that can kill quickly, the detective work always has to start there.
All right, let's dive right into Section 1, the main suspect. The absolute most dangerous suspect in this lineup is myocardial ischemia. And simply put, this is a deadly game of supply and demand. Your heart muscle, the myocardium, is constantly demanding oxygen. But if the coronary arteries get blocked or narrowed, the oxygen supply just simply can't keep up with that metabolic demand. That oxygen starvation is exactly what causes that classic agonizing chest pressure. And if that starvation goes on long enough, say even just 20 minutes, the heart muscle actually begins to die. That's a myocardial infarction, or what we all know as a heart attack.
Moving right along to Section 2, interrogating the symptoms.
Once doctors know what they're looking for, the interrogation begins. The first thing they need to establish is the pattern of the pain. On one side, we have stable angina. This is a known, totally predictable pattern. The pain typically kicks in during physical exertion or stress when the heart's working harder, and it predictably fades away within minutes if the patient rests or takes nitroglycerin. But on the flip side, that's the red flag: unstable angina. This is a terrifying shift. The pain might suddenly hit while the patient is just chilling on the couch watching TV. It lasts much longer, and it doesn't go away easily. Unstable angina is a massive warning sign that a heart attack could be imminent. Okay, I want to ask you a question that might totally challenge everything Hollywood has taught you. When a character on a TV show has a heart attack, they almost always grab their left arm, right? So based on actual clinical data, which symptom do you think more strongly predicts a true heart attack? Pain radiating down the left arm or the right arm?
Believe it or not, radiation of pain to the right arm or shoulder actually has the highest likelihood ratio for predicting an acute myocardial infarction. No way, right? Now, pain in the left arm is definitely a classic symptom, for sure. But if a patient comes in reporting that the pressure is radiating into both arms, or specifically the right arm and shoulder, the probability that it's a true heart attack shoots up dramatically. It's just a fascinating, totally counterintuitive clue.
But the interrogation definitely doesn't stop at the heart, because other conditions can perfectly mimic an infarction. Take an aortic dissection, which is a catastrophic tear in the body's main artery. Patients often describe this not as a pressure, but as a sudden, intense tearing or ripping pain that shoots straight through to their back. Then there's pericarditis, an inflammation of the heart sac, which causes a sharp pain that remarkably gets better if the patient just leans forward. Oh, and we absolutely can't ignore the psychological element. Up to 10% of emergency chest pain cases are actually panic disorders.
All right, let's step into Section 3, searching for physical clues.
You know, sometimes the most important evidence presents itself before the doctor even touches the patient with a stethoscope. Clinicians are trained to look for something called Levine's sign. This is an involuntary, almost universal body language cue. A patient will describe their chest discomfort not by pointing a single finger, but by holding a tightly clenched fist firmly against the center of their chest. It visually communicates this deep, squeezing, heavy pressure, rather than just a sharp, localized pain.
And the hands-on exam provides immediate, actionable intelligence. Checking vital signs for a racing heart or dangerously low blood pressure can instantly signal shock. Listening to the lungs might reveal pulmonary edema, which is fluid backing up into the lungs because the heart is failing to pump properly.
A stethoscope to the chest might uncover a brand new heart murmur, pointing to a ruptured valve, or a friction rub that screams pericarditis. Even checking the pulses in the arms and legs is absolutely vital. A missing pulse in one arm, that is a massive red flag for that tearing aortic dissection we just talked about. This brings us to Section 4, running the forensics.
Once we're in the forensic lab, the clock is quite literally the enemy. Professional guidelines mandate a really strict timeline here. Within exactly 10 minutes of a patient's arrival with chest pain, an ECG must be obtained. The whole goal is to immediately spot any ST segment elevation. That's the telltale electrical signature of a completely blocked artery. Now, if the initial ECG is normal but the patient is still hurting, doctors run serial ECGs every 30 to 60 minutes. And parallel to all this, between 1 to 3 hours, they draw blood to look for a very specific biomarker.
That biomarker is cardiac troponin. You can think of troponin as the ultimate lie detector test for heart damage. It's a protein that's normally found strictly inside your heart muscle cells. It has absolutely no business floating freely in your bloodstream. But when myocardial ischemia causes those heart cells to die, their cell walls break open and they spill cardiac troponin directly into the blood. By using modern high-sensitivity assays, doctors can detect even microscopic amounts of this damage within just hours.
But here's the catch. Simply finding troponin isn't enough. The forensics require interpreting the pattern. If a patient has an elevated troponin level, doctors watch closely to see if those levels are dynamic, meaning they significantly rise and then fall, or if they just remain stable. A stable, chronically elevated troponin might just mean the patient has some underlying structural heart disease, but a dynamic rise and fall, that signifies an acute injury. And if that rising and falling happens alongside a lack of oxygen, well, the diagnosis of a myocardial infarction is officially confirmed.
And finally, we arrive at Section 5, scoring the final verdict.
So how do clinicians synthesize all these clues, the interrogation, the physical evidence, the blood forensics, without just guessing? They use integrated clinical decision pathways. A super common one is the HEART score. It's a really elegant system that assigns objective points based on 5 categories: history, ECG, age, risk factors like diabetes or smoking, and finally troponin levels. By mathematically combining these totally diverse clues, the doctor gets a hard, calculated risk score. The beauty of this is how definitive it can be. Using systems like the HEART or EDAX scores, a patient with a low score, say 0 to 3, is classified as low risk, and the negative predictive value for these low-risk groups is over 99%. That means clinicians can confidently look at a terrified patient whose chest was hurting from a severe bout of acid reflux and say, "You are safe, you are not having a heart attack, and we can discharge you right now." It's an incredibly powerful tool for preventing unnecessary hospital stays while making sure we catch the truly sick.
Of course, there are always patients who fall into a gray area of intermediate risk, where the immediate emergency is ruled out, but the verdict is still kind of up in the air. For those cases, we have an entire arsenal of advanced non-invasive imaging. Coronary CT angiographies can visually map out blockages in the arteries. Stress testing pushes the heart to unmask hidden issues. Echocardiograms use sound waves to look for mechanical failures. And cardiac MRIs can beautifully map out the exact structural integrity of the heart tissue.
So, we've gone from a totally chaotic, life-or-death emergency room entrance to a highly calibrated scientific process of elimination. We've seen how the medical detective carefully balances the 42% likelihood of a harmless stomach issue against the ticking clock of a dying heart muscle. So, I leave you with this. The next time you hear someone mention chest pain, what will you see? Will you just see sheer panic, or will you see the elegant logical puzzle that dedicated clinicians are solving every single day?